so we will directly jump on to our third talk of the day. Our third talk will be given by Professor Rafeal Esteban. He was going to talk to you about chronic hepatitis B and hepatitis D co-infection. Does it matter? Professor Esteban is the head of internal medicine and liver unit of the Hospital Universitario Vall de Hebron, Barcelona, Spain, and professor of medicine at Universidad Autónoma de Barcelona. Professor Esteban, I would welcome you to take the stage, please. Thank you.
Thank you. Thank you very much. Thank you to the organizers for inviting me. This is a privilege to participate in this important meeting. My task today is very easy. So it's to answer this question. Chronic hepatitis B and D co-infection, does it matter? So the answer is yes, and I live. So that's very easy. So there are some populations that are more likely to acquire hepatitis delta infection. Those in countries without vaccination programs or HBsAg positive individuals are at risk of being infected by delta virus. Newborns and infants of infected mothers, because HBV can be transmitted via the route. People who inject drugs and commercial sex workers. In those populations, in countries with vaccination programs, migrants from endemic countries without vaccination programs, or people, residents who missed vaccination because they were older or high-risk history. Again, men who have sex with men and hemodialysis recipients are people at risk of acquiring delta infection. But this is the important message. All HBsAg positive patients are at risk of HDV infection. So the prevalence is different among different countries and different regions. It is very difficult to calculate the exact number of delta infected patients, but let's say between 12 and 60 million people in the world are infected by delta virus. So this is an important health issue. So I have a question for you. So who should be screened for HDV? All HBsAg positive? Yes, all individuals. 2, no, only those with a risk factor. Only those with liver cirrhosis, or only those anti-HBe positive. So please raise hands, those who answer number 1. Okay, thank you. This is the majority. That's it. All HBsAg positive patients should be screened for delta hepatitis. These are the recommendations from 2 scientific organizations, the EASL, the European Association for the Study of the Liver, and the AASLD. So, just to summarize, the EASL says systematically exclude, including co-infections with hepatitis D, hepatitis C, and HIV for all patients with a liver disease. The AASLD is more precise, so they focus on persons who were born in regions with reported high HDV endemicity. So the Americans, they are very clever. They always translate the problem outside. So there is something that they do every day. So they probably have more Chinese people in US that in China. So people who live in US may be infected by Delta virus. This is very easy to understand. Persons who have ever injected drugs, fully agree. Men who have sex with men, individuals infected with HCV or HIV, persons with multiple sexual partners or any history of sexually transmitted disease, and individuals with elevated ALT or AST with low or undetectable HBV DNA. So I think it's much easier. Every HBsAg positive should be screened for Delta. This is cheap, this is easy to do, and just to check for antibodies anti-Delta. This is an example of HDV screening and disease burden in a US center. And you can observe that even in a good center, only 13% of HBsAg positive patients were screened for Delta. And we are talking about US. This is not the third world. So I think that we cannot forget that every HBsAg should be screened for Delta. In our hospital, we implement a program, a reflex testing in HBsAg positive patients last year in 2021. And you can observe pre and post reflex test that we got a lot of patients and we screened more than 90% of the HBsAg positive patients. So that's easy. So every HBsAg immediately has a reflex test for anti-Delta antibodies. I think this is the way to go. This is the way to improve the situation and to generate patients with Delta. And this is especially important now when we have some new drugs to treat the situation, to treat the infection. This is the result of a HDV reflex testing in France. This is a retrospective survey for one center, but from 10 years, over 10 years. And the results are very similar. So the reflex testing led to an increase in HDV screening rates over time and exceeds 90% from the situation pre-reflex test. This is easy. This is a clear message for you. This is to take home message. So C, B, please think D. It is clear that every HBsAg should be tested for anti-Delta antibodies, and then those positive for HDV RNA. So again, I have a question for you. So the risk of developing liver cirrhosis in patients with chronic hepatitis Delta, one, it is similar to those with chronic hepatitis B. Two, it is higher in those with Delta and undetectable HDV RNA. Three, the highest risk is in those with chronic Delta undetectable HDV RNA. And four, it doesn't matter. So please raise hands for the answer number 3. Good, 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 good. You know everything. I live. So you don't need any explanation. You know everything. So in fact, it is very clear that patients with Delta are at higher risk of severe liver disease than those with HBV monoinfection. In every situation, cirrhosis, HCC, liver transplant, hepatic decompensation, and even mortality is higher among patients infected with Delta. You can observe that liver cirrhosis is 2 to 3-fold in patients with Delta compared to HBV infected, monoinfected patients. And you have in this slide the probability of developing clinical events in chronic hepatitis Delta. And the main issue here, the main problem is persistent HDV RNA. Those with persistent HDV RNA present a higher decompensation, an annual rate of liver cirrhosis higher, and finally liver cancer. Again, male gender is always bad, but in this case, again, there is a negative factor to develop hepatocellular carcinoma. Cirrhosis at diagnosis is obviously one of the worst factors, and lack of antiviral therapy, of course. This is a survey from our hospital, from our patients, followed for a median of 8 years. And you can observe that the persistence of HDV RNA is the main factor to go to progression of cirrhosis, to liver decompensation, to HCC, and even to death. So we should try to complete negativize the HDV RNA. Again, this is an analysis from 93 different studies, and you can observe that the risk of HCC among those Delta patients is high, is twofold compared to monoinfected B patients. Once again, the long-term survival in patients with undetectable HDV RNA is good, and again, the persistence of HDV RNA is the main factor to decrease the survival of these patients. And finally, it is very important, and again, this is a take-home message, how to differentiate HBV, HDV co-infection from HBV, HDV superinfection. And the answers are by the presence of E antigen, by the presence of IgM anticore, by the presence of anti-delta, or none of the above. So please raise hands, those who would like to answer by the presence of IgM anticore. Good, good, very nice. But very few raise hands, so I don't know whether they don't want to show it or they don't know the answer. Anyway, this is correct, so by the presence of anticore IgM. You have here the different aspects of the infection. The simultaneous co-infection is good. Usually, on the left of the panel, usually results in spontaneous clearance of both viruses. That occurs when a patient is infected simultaneously by B virus and Delta virus. The other option or the other situation, which is absolutely different, is the previous HBsAg positive, previous HBV infected, who becomes infected by Delta. And this is the worst situation because B allows the replication of delta over time, and these patients progress to chronic liver disease and to liver cirrhosis. It is right that some of these infected patients over time, after years of infection, may clear the virus and may be completed off the risk of progression. But there is a few patients. This shows you the different stages of HDV, but again, the presence of anti-core IgM is essential to differentiate co-infection or superinfection by delta. This is the algorithm for the evaluation of delta virus. This is very easy. Every HBsAg positive patient should be screened for delta. If HDV RNA is positive, and the LT are elevated, we need to assess the liver fibrosis by non-invasive procedures like elastography or by liver biopsy and treat those patients. So in summary, and I will finish with that, again, please see B and think in D. Patients with chronic hepatitis delta have a worse outcome compared to those mono-infected with HBV, and diagnosis of chronic hepatitis delta requires the determination of anti-delta antibodies and HDV RNA. Thank you very much for your attention. Thank you.
Thank you very much, sir. It was an amazing presentation. If we had listened to Professor Esteban's first lines and raised both our hands to his yes, so we would have finished a lot earlier.